Chlamydia trachomatis, Unmasking the Silent Epidemic by Samantha Ruiz. A 21-year-old female presents to a university health clinic for her routine annual exam. She reports no symptoms, including no pain, no discharge, and no abnormal bleeding. However, her clinical history reveals multiple sexual partners over the last 3 months with inconsistent condom use and no prior history of STI screening. This case highlights the illusion of health. While the patient feels healthy, her demographics, including being within 15 to 24 years of age, combined with her recent sexual history, puts her at a higher risk for sexually transmitted infections. Based on this, the physician makes the critical clinical decision to recommend routine STI screening, specifically for Chlamydia trachomatis. A vaginal swab was collected from the patient for testing. The diagnostic gold standard used is the nucleic acid amplification test. This diagnostic tool is highly sensitive because it is capable of detecting and amplifying even small amounts of bacterial DNA or RNA. This makes them ideal for diagnosing asymptomatic cases. Another important feature is that results can come back in as little as 20 minutes. In this case, the result came back positive for Chlamydia trachomatis. The image shows a flocked swab, which is used to collect the sample from the patient, and it is suspended into the collection kit fluid for transportation. So what exactly is this pathogen? Chlamydia trachomatis is classified as an obligate intracellular gram-negative bacterium. What this means is that the pathogen cannot survive outside of a host cell. This trait defines its entire life cycle and how it interacts with the human immune system. There are 3 primary pathotypes of Chlamydia trachomatis. The one relevant to our patient is the urogenital pathotype, caused by serovars D through K. It ascends the reproductive tract, but is often asymptomatic. It is the leading cause of bacterial STIs globally, and it can affect both males and females. If left untreated, the pathogen continues to ascend, leading to severe complications, especially in women. This includes pelvic inflammatory disease, which causes widespread inflammation and tissue damage in the upper reproductive organs, ectopic pregnancy caused by fallopian tube damage. It poses severe life-threatening risk to the mother, and lastly, infertility. The second pathotype is ocular chlamydia or trachoma. It is caused by serovars A through C. This involves chronic inflammation that scars the eyelid, eventually causing the eyelashes to abrade the cornea. It is the primary cause of preventable infectious blindness worldwide. The image does a good job at highlighting the stages and progression of this disease. We see the initial inflammation ultimately resulting in the patient's blindness. The third and most invasive form is lymphogranuloma venereum, otherwise known as LGV. It is caused by serovars L1 through L3. This pathotype targets the lymphatic system, forming invasive necrotic lesions on lymph nodes, and it is of highest prevalence among males who have sex with males. And the pictures show just how invasive this infection truly is. To understand why this pathogen is so hard to detect, it is important to understand its biphasic life cycle. Chlamydia trachomatis primarily exists in two forms: the elementary body, which is the infectious but metabolically inactive form that travels between cells, and the reticulate body, which is the active, replicating form found inside the host cell. It can actually form a third type of body known as the aberrant body under stress, and the entire life cycle takes between 36 to 72 hours to reach completion. The bacterium also uses unique immune evasion techniques. First, it interferes with T cells by down-regulating major histocompatibility complexes, making the infected cell functionally invisible to the host immune system. It also inhibits apoptosis by releasing proteins that prevent the host cell from self-destructing. What this does is it makes sure that the cell is kept alive just long enough for the replication process to reach completion. Returning to our 21-year-old patient, her lack of symptoms was not a coincidence. We now know that it is the result of millions of years of evolutionary design. By hiding inside of protective inclusion vesicles, entering dormant states under stress, and silencing the immune system, the pathogen is able to ensure its survival and remain undetected. Treatment varies by pathotype. For our patient's uncomplicated urogenital infection, a 7-day course of doxycycline is the first-line treatment. Single-dose azithromycin is an alternative for pregnancy or adherence concerns, as well as for trachoma. More invasive infections like LGV require an extended 21-day course of doxycycline or erythromycin. The reality of this infection is staggering. Over 1.5 million cases were reported in the US in 2024 alone. Highest infection rates are seen in ages 15 to 24 and in minority populations. However, because 50 to 75% of infected individuals are asymptomatic, the global prevalence is likely massively underreported due to the pathogen's evasive nature and the lack of universal screening. Managing a positive case should involve 3 key steps. First, ensure that the patient adheres to the treatment plan in order to prevent persistent infection. Second is containment. All recent sexual partners should be notified and tested. Finally is verification. A follow-up test should be scheduled 3 months after treatment is completed in order to confirm that the pathogen has been completely cleared. In conclusion, breaking the silent epidemic requires a multi-pronged public health approach, including robust surveillance, expanded access to affordable testing, safe sexual practices, and partner awareness. By unmasking the pathogen early, we can prevent its most devastating long-term consequences. Thank you for listening to my presentation. These are my references.